last topic, topic 4 of the Global Dementia Legacy event in Japan. The topic 4 is the future initiatives. There are a lot of discussion held yesterday and today. Yesterday through subspecialty meetings, and today throughout the day, to create a future and to share the dream is the topic of future initiative. The chair is Dr. Akira Honma from Tokyo Dementia Care Research and Training Center in Japan. Thank you very much. So we are starting a discussion for topic 4, future initiatives. Yesterday we had the similar discussion, which is the enhancing awareness and education in society and living well with dementia in the community and other matters, and how education can be used in prevention and also treatment of people with dementia. How important education is something that is extremely obvious. But the challenge is how we can really implement what we would like to do. Then that doesn't really limit the discussion of education, but the achievement of the education and also the achievement by the social activity, there are metrics or measurement should be there. That is a consensus, and that was stressed by the keynote speaker today. That's one point. And the second point is throughout the educational activities, we can share the understanding, but we are from different countries and we are from different cultures, so there are uniqueness in the different countries. There's no one single magic bullet to be applied to the entire globe. Consensus is important. We all understand that. However, we should understand the differences, and also we should expand that not only to G7 countries, to the non-G7 countries, which of course need to cover Asian nations. When we would like to communicate the messages about this topic, what are the frameworks and what are the processes needed to be used is something that we all need to think about that. That is the second challenge. So based on this understanding, at this topic for discussion, we have the panelists listed up here, and also after the opening remarks, Dr. Mark Wortman of ADI is going to give us a presentation after he introduces himself. Then after that, we will follow the order of the presentation. Please keep the time at 6 minutes per presenter, because this session has to be concluded latest by 5 o'clock. That is a mission being given by Secretariat, and they are very strict. So I appreciate everybody's cooperation.
So again, good afternoon. And I think very much in line with the session that we had yesterday, which was about exchange of information and education. There were the two main elements. There is a new tool, a new body at the global level for Alzheimer's and dementia. And this was an idea, and I have to commit to the UK Department of Health to create a global Alzheimer's and Dementia Action Alliance. And the idea is that we need to broaden our work from the dementia community into the broader NGO world internationally. So this is an ask that we did to other NGOs that are not dementia related. For instance, the International Red Cross, the NCD Alliance, HelpAge International. Can you work with us together to spread the message? And we got a very positive response at the meeting in May at the World Health Assembly in Geneva during the annual meeting from the World Health Organization. So this group was created, and the purpose is to raise global awareness, to make our societies more dementia-friendly and more inclusive to the cause, and get help from other international bodies. And that's the Global Alzheimer's Dementia Action Alliance. There have been a number of activities so far, so invitations sent out to 20 international non-government organizations, 10 of them already accepted. You know, in the international world, it takes a bit of time, so sometimes the board needs to meet before they can take a decision. So we're waiting for the other 10, but I'm sure that will be okay. We shared some public information on risk reduction for dementia during World Alzheimer's Month, this September 2014, so that these organizations could use that. We're now in the process of developing a general toolkit how civil society organizations can raise awareness and make communities more dementia-friendly, including links to the global health agenda, where many of these are present. We're planning to set up a newsletter and a website, and we will ask all of the member organizations to make an internal plan next year how they commit to dementia and what kind of action they can take themselves. How you can help? Well, there is no fee to participate for these international NGOs, although we kindly ask for a voluntary contribution. But the main thing is that they execute a simple agreement and that they sign the charter that we made and identify the key contacts in their organization who can work sometimes or often with the national dementia organizations to raise the issue. One thing we haven't done yet is reaching out to the governmental development aid agencies of the G7 governments and beyond, because they were part of the initial plan as well, to be able to reach out to all parts of the world, because there are still many countries where there is no dementia society or association at all. But there are people in need as well. So we think we need these agencies, and maybe if people from governments here who know how that works, then I really like to speak to them today, how we make these things work. We think it's the little things that makes the world different, and I think in the previous session we have seen how important that is. If you want to contact us, there is a Twitter and email account, and soon there will be a website as well. And this is why it's important, the number of people with dementia worldwide, and especially those in lower and middle income countries in the future. And this global alliance is one of the ways that we can support them. Thank you very much.
Thank you very much. I think it's a very clear-cut action that's underway right now.
Speaker, which is Tom Wright, the CEO of Age UK and Age International. Tom, the floor is yours.
Thank you, Mark, and good afternoon, everyone. Age UK and Age International is perhaps the world's leading NGO focused on ageing, working both with the HelpAge International Network and indeed with many other organizations. And we focus on lifelong cognitive aging, and we specialize in both comorbidities, long-term conditions, and dementia. And I want to share with you this afternoon models that we've been testing in the UK, which are transforming outcomes for older people with dementia and long-term conditions. The start point for us is a lifetime approach to cognitive aging. Now, of course, there's been much discussion at the Conference on Research and Cure, but recognizing the multiple diseases which can make up and contribute towards dementia, then perhaps there's no simple cure. And therefore we need to focus as much on maintaining functional capacity as we age, i.e. maintaining independence and preventing disability. And that's very much the approach of Age UK and Age International. And our work is very much informed by one of the most important scientific projects in the world, which is the Disconnected Mind at Edinburgh University. This is a unique cohort of older Scottish people tested in the 1920s and 1930s and now receiving advanced brain imaging in their 70s and 80s. And what this is telling us is that aging takes a vastly different toll on each person. And those who are fit, don't smoke, have a good diet and bilingual have much better outcomes in terms of cognitive capacity in later life. This has just been written up in Science, published on the 31st of October, and do send me an email if you'd like a copy of this work. But as we know, and from our research, for most, dementia is not a single condition. 85% have other long-term conditions, and as you can see on this slide here, such as heart disease and strokes, which equally increase with age. We also know that diabetes and depression massively exacerbate the probability of dementia. And indeed, many have multiple conditions, and those with dementia are far more likely to have poorer outcomes with many of these multiple conditions. So, we've been leading a revolution in the UK for those with long-term conditions and dementia. And effectively, we focus on the individual person and have an integrated and person-centered approach. And we focus at the primary interface with the general practitioner, with the doctors, and we use a risk stratification process. But all our work starts with a guided conversation looking at what outcomes the individual patient and their family would like to get from their healthcare support. And then we wrap around those individuals a whole range of services. We use multidisciplinary teams based within the primary care setting. And indeed, we combine both medical and social interventions. And the combination of these two has a dramatic impact on those people that we're working with. And perhaps just to share with you some of those outcomes, and indeed there's been much discussion about the lack of evidence base over this conference and the lack of evaluation and financial benefits resulting from new models of care around dementia. Well, with the models that we have established, the potential savings to the state and to health providers is absolutely huge, with slightly earlier intervention and better models of care. On our work to date, early financial calculations tell us that for every £1 that we invest, we save £4 of downstream health and care costs. That's an enormous saving. Perhaps just as importantly, there's a 30% reduction in non-elective hospital admissions for those people being managed in this type of integrated care. And using the Edinburgh and Warwick mental well-being test, we see a 23% improvement in the well-being of older people with long-term conditions and dementia. And if you extrapolated that to the UK health and care system, we could save it over £1 billion a year through these type of interventions. And as long-term conditions and comorbidities increase, you can see that those savings will grow dramatically in the years to come. So thank you very much for listening to me. My email address is on that slide. If anyone would like a copy, which I have here, of our approach and our model, or indeed a copy of the science article on disconnected minds, do please email me and I'll send a copy of both to you on return of email. Thank you very much.
Thank you, Tom, and thanks very much for keeping the time. The next speaker is from Kyushu University in Japan, Toshiharu Ninomiya. Oh, did I change the order? I used the order from the book. I'm sorry.
I would like to speak in Japanese.
Thank you very much for your introduction. I am doing epidemiological study in Hisayama town of Fukuoka Prefecture. I'd like to introduce to you some of the results from Hisayama study for dementia. Hisayama study is a pretty well-known study in Japan. Hisayama town is located here in the northern part of Fukuoka city, and Hisayama town, in terms of age distribution and proportions of labor population by industry, kind of reflects the entire Japan. So Hisayama town can be a very much standard sample of the entire Japan. And around 1960, so which is around 50 years ago, epidemiological study started in Hisayama town. And in 1960, 1970, 1980s, every 10 years or so, a cohort was set up to take a look at the characteristics of each age group. And then we are taking a look at those people over 40 years of age in this town. And we have very high participation rate is over 80%. Follow-up rate is over 99%. And what's very important about this is that those people who actually perish in this town donate themselves, and we were able to do autopsy in those people to identify the real cause of death in the brain, also in the heart. So the autopsy rate is as high as 75%. So since 1985, we started to take a look at the dementia in Hisayama town. Apart from other lifestyle-related diseases, every 6 years to every 7 years, we are taking a look at the over 90% of those people who are over 65 years of age for dementia. MSSE neuropsychological test is being done to identify those people suspect of dementia, and psychiatric doctors or experts actually give a definite diagnosis. And for the diagnosis rate of over 90%, of course, we should not only provide health checkups, but also visit to their own houses to identify dementia. So this data is a very high precision data. And based on this data, we create a dementia cohort to follow up. So first, we thought we needed to confirm the prevalence of dementia in Hisayama town. And this study started in 1985. And we are taking a look at the prevalence of total dementia increase over time. So since 1985, it was around 6% up until 1998. But then after that, there was a rapid increase. In 2005, 12.5%, and with the age adjustment, it was around 16%, which is in line with the national data from the ministry. Vascular dementia, no change in prevalence, but Alzheimer's disease rapidly increased, and even with the age adjustment, this tendency is still there. So it's not only due to aging. There are other factors contributing to this increase. And in our Hisayama study, with the awareness that we need to prevent dementia, what can we do? We started to think about that. So we thought we needed to prevent. So what do we need to prevent? Where do we need to intervene? We didn't know. Therefore, we decided to identify risk factors. So we have done so. This data shows hypertension, 668 people who are over 65 years of age in Hisayama town. We followed them for over 17 years. Hisayama study itself has been running over 50 years. So we could take a look at the comparison between late life and midlife. And hypertension didn't have nothing to do with Alzheimer's disease. Blood pressure was not correlated. However, vascular dementia, red is midlife and blue is late life. There was correlation for both. However, midlife, the slope was more steep for the red bars, meaning that the midlife was more correlated with vascular dementia. And now, diabetes, of course, is increasing. Is it related to Alzheimer's disease? Yes, it is. The risk is twice as much as high than non-diabetic patients. And of course, I can't cover everything because of the time limitation, but what we've found out of Hisayama study is here. These are the risk factors for dementia. Number one, hypertension from midlife already. Diabetes, especially postprandial hyperglycemia is important, and smoking, which has not been submitted as paper yet, and genetic factors have been identified. Protective factors are follows. One thing is Japanese diet, a lot of vegetable and a lot of fish, and also milk. Balanced diet is very important, as well as exercise. And so people with more exercise have less risk for dementia. And of course, we feed up this kind of information to the people in Hisayama town. We would like to create kind of a risk scoring so that they can prevent dementia as much as they can. However, that's not enough. Of course, we need to develop new biomarkers in the future. But in Hisayama town, because the population is limited, that's not really possible. Therefore, what we are planning right now is take a look at the similar clinical cohort across Japan. And right now, we are looking at 5 or 6 sites as possibility to have 10,000 people cohort, which is pretty big cohort. We would like to take a look at the metabolome and omics and etc., so that we can identify etiology of dementia and establish preventive strategy. So that's all about it. Thank you very much.
Thank you very much. A very interesting study, I think. And I will now take better care of the order. So the next speaker is Mrs. Hiroko Sugawara, and she will speak about the supporters network in Japan. She's leading the program on the supporters and the Orange Plan. The floor is yours.
はい、今朝朝早くから、安倍総理が認知症サポーターのご紹介いただいて、その後ずっと認知症サポーターをご紹介いただきましたが、これから認知症サポーターキャラバン一本に絞ってお話。
I would like to talk about the dementia support caravan. The Prime Minister Abe in the morning talked about the dementia supporters. Now, the purpose of this the dementia supporter caravan is to raise the awareness of the dementia and eliminate the prejudice and encourage people to receive care and support, and also being identified and receive early detection. Now, the Ninchi-sho supporter, meaning the dementia supporters, the people who support the people with the dementia. And there's a caravan mate who is the leader. And we have the numeric target. In 2014, 4 million, and in 2017, 6 million. That was the numeric target. But actually, in year 2009, we achieved 1.5 million, and doubled in year 2010, the 2.9, and year 2014, as of September, we exceeded the 5.5 million supporters. So by the end of this fiscal year, we are able to achieve 6 million the dementia supporters. So we don't have to wait 2017. So after this year, I'm sure that we have to have a new numeric goal. So that is the current situation. Now, I would like to talk about the framework of this supporter caravan. So we needed to make sure that we provide multi-tiered support so that people with dementia can stay in the community. So we have the National Caravan Mate Coordinating Committee, which I belong to, and plus companies and organizations. We train caravan mate. A caravan mate is trainers for the in-house supporter training, and caravan mate provide training to develop the another supporters. On average, every month we have 75,400 new supporters every month. So we have the first layer, second layer, and a third layer, actually, first tier, second tier, and third tier. This tiered condition will help the dissemination of accurate and correct understanding about the dementia and provide the comprehensive support. So this is based on the importance of knowledge transfer and multi-tiered support and infrastructure using unified learning resources. Now, the expert of dementia who provide and transfer knowledge to caravan mate. There are about 100,000 caravan mates and multidisciplinary. There are care managers or social workers and some the community nurses and sometimes that care staff. So these the multidisciplinary caravan mates form a team to provide supporter sessions. And these sessions are actually training sessions for new supporters. So that is how we transfer our knowledge. Right now, the range of the age of the supporter is 10 years old to 100 years old. And 60% to females, 40% to male, grocery stores, police and the junior high, the grade school, high schools. There are supporters all over the community, and these supporters provide watch-over care to the people with the dementia and families. If there are care needed, then they contact caravan mate or municipalities. And if healthcare access will be necessary, then this supporter will help the people with dementia and also the family to have access to the medical system. So this is the comprehensive integrated support which embraces knowledge transfer, multi-tiered support, and infrastructure. So it's been 9 years since we first established this system. So this is the effect. So there is the two dementia supporter, initial supporter per one person over 65 years old. These municipalities or towns achieved that. So 73% of the people with the CDL, 73% is has an initial presentation to the doctors when they are at the CDL 1. And in terms of supporters' actual activities, we are also developing the nighttime supporters, 1, 2 o'clock in the morning, or 3 or 4 o'clock in the morning. Caravan mate has the understanding of who are active during the nighttime or early morning. So the caravan mate develop nighttime supporters. There's a Kikuchi city of Kumamoto who achieved the no wandering around at nighttime because of this supporter system. And let's take a look at the overseas countries. There's a UK Dementia Friend in year 2010. In New York, there's a Japanese American Association of New York, Toronto Japanese Social Services in Toronto and Vancouver, and also in Düsseldorf in Germany. The German-Japanese association are also establishing a similar system. Last but not least, this is the message from a 12 years old kid supporter. Orange ring as you know, as Dr. Hasegawa introduced, that this orange ring is the proof that these people are the dementia supporters, and orange ring connect the world with the kindness, and all the islands are connected with this kindness, and the world is connected, and also the globe and planet should be connected with the kindness. Thank you.
If you want me to connect the national Alzheimer associations with the countries that you're looking for, I'm happy to do that and do the training myself in the Netherlands. Okay, we quickly move on with Jürgen Schäftlein from the European Commission. The floor is yours. Thank you very much.
Good afternoon. Thank you very much. I have uploaded the presentation, but I cannot see it, so I don't know what. It's appearing. Good, very good. Thank you. I'll go through this presentation very quickly. I'm representing the European Commission, which is one of the institutions in the European Union. I would like to slip very quickly through these slides. Some are more for illustration of our activities. I would like to welcome again the effort to build global action against dementia. And we in the European Union, we have developed over the past years an example of some collaboration on dementia between 28 member states. The European Union has 28 member states. We have in the European Union more than 6 million people living with dementia. We have the high economic and growing economic costs resulting from that. But it's very important also to stress that we have very diverse situations in Europe. We have more wealthy countries, we have less wealthy countries, and we have different health and social welfare systems. And our role at European Union level is to support member states in their actions by developing collaboration and offering collaboration between them. And in the field of dementia, that had its origin in the year 2009, and in fact it had been stimulated by France, which was the country which had the EU presidency at that time. And the collaboration on dementia, which then was implemented, addressed the following priorities: early or timely diagnosis on dementia, better understanding of dementia, best practices in care for people with dementia, and respecting the rights of people with dementia. Very recently, we have published an implementation report about the activities in the context of that strategy. And I would like to highlight just a few examples of activities, and I would like to focus on a so-called joint action, then a European Innovation Partnership, and research activities at EU level. Let me begin with the joint action, which is a collaboration which had involved 19 member states. It was free to member states, but 9 to participate, but 19 wanted to do so, and they funded this collaboration, plus it was supported from the EU Health Programme. And this ALCOVE joint action developed over 3 years a set of recommendations on toolkits on the issues that were addressed. And just to show you an example of one of these toolkits, it includes very precise recommendations on process and implementation of the activities. This joint action has been very successful, and member states showed interest in having a second such collaboration, and this is under preparation. This time it will be led by the United Kingdom, specifically Scotland from the United Kingdom, and you can see here the themes that will be addressed by this second joint action. Another activity at EU level, which is also one which brings together regions from the Europe to identify good practices and to scale them up in the broader context of aging and active and healthy aging is the European Innovation Partnership. It is an activity that's linked to the EU strategy for growth, and there are two activity strands related to dementia: prevention of frailty and cognitive decline, and innovation for age-friendly environments. Here you can see 1,000 European regions are involved. A billion of euros has been mobilized, and this leads to the identification of good practices. Here is an example from Kinsale community about creating circles of care for people with dementia. Another one, age-friendly environments through simple changes which have led to reductions in falls through quite simple measures in residential homes. At EU level, we have also an active policy on e-health, where a number of projects have been supported and further ones are on the way. And these activities and the outcomes they were summarized in this dissemination report, which I mentioned. And they will also be presented next week, in fact, at an event under the Italian EU presidency, Dementia in Europe, a challenge for our common future, where also the work under the initiative Global Action Against Dementia will be presented. We have also a group of governmental experts on dementia, where governmental experts from ministries of health are going to meet regularly and work together. And in future, we plan to continue with coordination of EU policies and supporting member states in their actions. We are going to launch the second joint action on dementia. We are going to continue with work in the research context and on e-health solutions. And we are very pleased to be part of the initiative Global Action Against Dementia. Does it make a difference, these activities at EU level? We believe yes, because it brings the large countries together. Even large countries cannot cope alone with dementia, and it allows the smaller countries to liaise with them and to contribute to the work. And an indicator of the change that was achieved is that in 2009 only France had a national action plan on dementia in the EU, but now it's 16 EU member states who have such a plan and are working on it, and we believe that we have made a contribution to that. Thank you very much.
Thank you very much, and congratulations for summarizing all the work that is happening in Europe in 7 minutes. Well done. Almost impossible. The next speaker is Mark Pearson from OECD. You already informed us this morning about the care report, so we're very interested to hear again from you.
Thank you very much. Yes, you're very kind to give me a second chance to speak to you. Maybe very stupid. But anyway, rather than go through describing all the different projects that we're doing at the OECD level, well, I will just mention them very briefly. We're doing lots of work comparing the content of national dementia plans. We're doing work on quantifying the value of supports for care, long-term care supports, including for people with dementia. Lots of work going on. To be honest, if I showed you this, you'd probably forget about it in a few minutes, because there's so many other fantastic projects going on. So rather than go through those various bits of OECD work, I want to focus on where I think we should be going in future initiatives, particularly at the international level, because of course that's what I'm interested in, being from an international organization. And I think we should acknowledge that at the moment we are benefiting internationally from the huge interest from a few leaders in dementia. We have the initiative of Prime Minister David Cameron to set up the G7 process. We had Prime Minister Abe here this morning demonstrating his support at the Japanese level. We are unlikely to have Prime Minister Cameron in power in 5 years' time, we're unlikely to have Prime Minister Abiy in power in 5 years' time. That's not a statement of politics, it's a probabilistic statement
Realistic,
based on past experience on how long Prime Ministers last. So the question I'm asking myself is, how do we make sure that their successors are also committed to promoting dementia at the international level? And I think that this will be difficult. And one of the reasons why it will be difficult is, well, my experience today. I've been doing a series of interviews with Japanese media, with NHK, Asahi Shimbun, Kyodo News Agency. All of those journalists have asked me the same question. Every single journalist has asked me, how does Japan compare with other countries in its dementia care? And you know, I couldn't give a good answer to that question. And that embarrassed me. I hope it embarrasses you. Because if we can't say how well countries are doing in their dementia care, how can we get attention from leaders in the future to put their attention, their limited amount of political capacity to pursue issues, how will we persuade them to put it into dementia? Coming back to what I said this morning, unsurprisingly, I've not changed my views since I spoke at 9:30 this morning. We have to do much better at measuring performance internationally in the dementia area. We must find ways of benchmarking how well countries are doing, so that when we get the successors for Prime Minister Cameron and Prime Minister Abiy, we can actually say, listen, you have to take dementia seriously because you're not doing as well as other countries, or because you are the leader, you're doing better than these other countries, so it's your responsibility to go out and sell what you're doing. There's a second role, I think, internationally that we should be doing, which is that we've heard some fantastic programs, initiatives on dementia policies in the past 2 days. But if we're honest, very few of them would pass the test of being absolutely scientifically rigorous. They probably are very beneficial, but we are struggling to prove that. And the main reason we can see, obviously, you've already alluded to it actually, is that we find it very difficult to measure what is our metric, cognitive decline, the speed of cognitive decline, the speed of functional impairments, the decline in well-being. Lots of different possibilities, but we don't have a common metric that we're using across countries, or even within countries. I think it's absolutely vital, if we want to maintain dementia at the top of the political agenda, that we find ways of actually measuring what we're trying to affect, and that we apply them internationally in a consistent way. So there's the two areas where I see the most scope for international action. We will be pursuing them, unsurprisingly, at the OECD. We have a group that's speciality is working with countries to develop how you measure the quality of healthcare. They will be looking at how we measure dementia care in order to see whether we can come up with new insights. And I hope that we will be able to work with other international organizations to make sure that this is a common endeavor and not just one that's run by the different international organizations separately. I should also say, we will also provide a forum for discussion of dementia in the future. We obviously very strongly support the Geneva event that will take place in March. But we have agreement from our science and technology ministers who will be meeting in 2015 that a large part of their discussion will be on dementia. And I hope the same will be the case for the meeting of health ministers that we're planning at the OECD level in 2016. Thank you very much.
Thanks very much, Mark. I couldn't agree more with you than this issue of measuring and surveillance is very, very under-resourced and not done enough. That's why ADI started its World Alzheimer Reports. But if we can work together, that will be fantastic. The next speaker is Dr. Shaka Saxena. He's even more on stage today than I. And he represents the World Health Organization. Thank you very much for being here, and we're interested to learn from you.
Thank you very much for giving me multiple chances. I will like to take only 6 minutes, so let me begin straight away. We have a number of initiatives that we are planning, but we will need all your support to make that happen. So these are tentative plans, and they arise from the statement that WHO DG made in December 2013 in London. And the statement was beginning with, "I can think of no other condition." And of course, that was before the Ebola epidemic. But more seriously, the commitment continues. And from the highest level in WHO, the commitment is still very strong on taking it forward. And we follow the two principles that we have said. Dementia has a global impact, and global solutions need to be found, and it is care today and cure tomorrow. WHO's dementia initiatives will be aligned around this conceptual diagram. The three elements are prevention, care and services, and treatment. And the means to achieve that will be the research agenda, policy, and knowledge exchange across the countries and other organizations. To begin with, on the research side, we are already undertaking an exercise of identifying research portfolios to begin with for G7 countries, but we would like to expand that. And also we are having a global research prioritization exercise, and we hope to present some of the initial findings in March in Geneva. We do subscribe to what was presented by OECD this morning, that dementia care and prevention require policy options, and this is the continuum of care pathway which we believe will facilitate this identification of policy options, starting from prevention and awareness raising, diagnostic and post-diagnostic services, community services and supporting carers, and supported or institutional care and end-of-life care, using the health system approach that the WHO has always espoused. We stand committed to supporting countries for developing and implementing dementia-friendly policies. We think Global Dementia Observatory, as a part of the Global Health Observatory, which we already have in WHO, will be facilitating long-term investment in dementia care by providing information and knowledge, and this will provide, hopefully, global epidemiological trends, policy formulation and adoption, country implementation through health and social care systems, and partnerships, and we will very much like to follow a uniform metrics that will be the basis behind some of these data that we would like to collect, not from a few countries, but if possible from all countries in a gradual way. A lot has been talked about since this morning, including during this session, about prevention, and we do believe that the risk factors for dementia are very similar to other non-communicable diseases, and we think there is evidence for many of them, and this needs to be incorporated in the messages that need to come out to the general population as well as to the policymakers. We also think that information and communication technology, again we had a session on that today, can be extremely helpful in amplifying the impact of what can be done for people. We have a very concrete project on that. We are calling it the iSupport, which will provide information and support to people with dementia and their family members in multiple languages, in multiple formats, including websites as well as mobile technology and SMS for people who use that, to provide the kind of information tailor-made to the people who have the need and to their family members. This project is already ongoing, and we hope that in about a year and a half, we will have this portal ready. Of course, lastly, we hope to welcome you all for the first Ministerial Conference on Global Action Against Dementia, which will be on 3rd and 4th of March. It is very kindly supported by the Department of Health UK and by OECD. The main objective will be to widen the prioritization of dementia as a global issue for countries, including countries in the middle and low income range. And again, we have talked a lot about the increasing numbers now and in future in some of these countries requiring clear policy options. We look forward to seeing you in Geneva. Thank you.
Thanks, Dr. Saxena, and we're going well with the time. So thanks everybody for keeping the time. Now, the last speaker for this session is a very important man in the UK government who leads the work on the global action against dementia. And the floor is now at John Rouse, Director General of the Department of Health UK.
Good afternoon, everybody. It's been my pleasure since last year to first organise with my team the G8 Summit and then to coordinate the global action against dementia work through the 3 legacy events in the UK and then Canada and now Japan. And in case we don't get another opportunity, can I just say a huge thank you to Japan for organising what has been an excellent legacy event, which I'm sure will help us as we go forward. So you've put so much work into the last 2 days, it is only right that we address the question, so what happens next? What will happen to all the work that you've done over the last 2 days and the conclusions which will be drawn? Well, first, if I can just set a little bit of context, the coordinating activity across the G7 is organised under the 12 commitments within the declaration that was signed by all the G7 countries back in December 2013. And it won't surprise you to know that care and also the role of civic society, of dignity and respect for people with dementia and their rights is absolutely centre of that declaration, and your event will contribute to the implementation of those clauses. The principle that we've adopted throughout the implementation work has been one of collaboration across sectors and across countries. And we keep 2 principles in mind at all times. The first is that it's about care as well as cure, that you cannot favour one over the other. And the second is about affordability and timeliness. The need is urgent because of the growing prevalence, but whatever actions we take, we must be mindful that we will need global solutions that work for low to middle income countries as well as more developed nations. So we are organising all the work under 4 main work streams: integrated development, which is about availability of drugs and treatment; finance, which is about increasing the levels of dementia research; open science and data, around sharing knowledge and data in a more open way and reducing duplication; and finally care and prevention, with a focus on the role of technology, but also, as I've said already, the role of civic society. If we then zoom in on care, we can look at what's happening on a global basis, and then I will briefly mention the UK's contribution. So on a global basis, you've already heard about most of the work that is being organised. If I start actually at the bottom with the Global Dementia Care Framework, this is work that's being led by the OECD to establish a core set of principles that any country, or indeed any city or town or local municipality, could use to think about their care framework. It isn't about having one solution, it's rather about providing some models and principles that different places can adopt. On the civic level, you've already heard from Alzheimer's Disease International about the Global Alzheimer's and Dementia Action Alliance, really embracing the role of civic society and allowing for the sharing of practice across nations. We're also doing a lot of work on evidence and reviewing the cost-benefit case for investments in care. If we're going to have affordable solutions that work globally, then we have to ensure that they are solutions that can be invested in by low to middle income countries, as well as those who may be able to afford more. And we also want to ensure that we develop care models that are truly personalised and that reflect the needs of different individuals in different cultures and different advancements of the diseases. So going forwards, we can learn, we can align, and we can build. We can learn from collaborations that have happened successfully in other areas, and we're particularly interested in what we can learn from collaborations in genetics or genomics, and also around HIV, AIDS as well. In terms of alignment, we think there is a critical role for our research organisations in treatment and care, and therefore the heads of the international research organisations and the way that they organise their work and improve their collaboration is crucial. And then we can build on the existing global commitments that have already been made. The resolutions that the WHO and the World Health Assembly have made on non-communicable diseases and also on mental health. What we're trying to build here is a sustainable medium-term platform, and that means that in Geneva in March, we need to move from G7 to truly global. And our plan is to try to create a framework that many countries can participate in. I think that those principles will need to abide by these 5 common themes. The first is that we must embrace many stakeholders, and that means working across traditional boundaries. The next solutions may come from high-tech companies, they may come from communities themselves, and many other stakeholders. We must be open to that disruption in terms of our thinking. Second, the principle must be one of collaboration, and sometimes that will mean taking risks, particularly, for example, around sharing data from failed trials and other types of data. But if we do not learn together, then we will duplicate effort and we will waste resources. Third, and this goes with collaboration, is sharing. But sharing also from citizens themselves, learning from people with dementia and their carers. The internet provides us with amazing opportunities to allow citizens to tell us about their experiences, tell us about their care, and so we can use that data to actually underpin much of our science. Fourth is to embrace the role of civil or civic society, and to recognise that whatever we do must respect cultural differences. This isn't about a global blueprint, it is a global framework in which individual countries can find their own paths. And finally, we will need champions. Those champions will be people with dementia, they will come from industry, from prime ministers, and from a whole host of other sources. We know from the evidence that that is what has been made the most difference in terms of breakthroughs in other types of disease. And so we look to see who are going to be our champions for dementia for the next decade. Thank you.
Thank you very much. It's an exciting overview. I think we have reached the end of this session. Thanks all speakers for your brief but powerful presentations. And we have a very short break, and then the room can be set up for the closing session. Thank you very much. Questions or not? Yeah, okay. Just a little improvisation, but there is a little bit of time for questions. 2, 3 questions from the room. Oh, there are already 2. Jeremy Hughes, and then Vladimir Hashinsky. Is there a microphone? Yeah.
Hello, yeah, Jeremy Hughes from Alzheimer's Society in the UK. I thought that presentation from the whole panel was very inspiring, and there's lots of innovation, but the danger of these conferences is we talk to each other. And if we go out into Roppongi Hills, we'll probably find most people won't understand what dementia is. So we have to remember that we're not just talking to ourselves, but we're talking to the wider public. And the one thing we've not talked very much about in the last 2 days is about education and young people. And I think the key message that we should add to the programme is doing the work we've started doing in the UK, which is to create a dementia-friendly generation, where we're working with schools so that from the age of young children onwards, they no longer have stigma and discrimination, but they see dementia as part of everyday life. The same kind of work we've done over the last 20 years around physical disability. Now we also need to be looking at inclusive and seeing people with dementia for what they can do, not for what they cannot do.
Thanks very much for your comments. I think we all agree.
My question is about Hisayama's study. It was quite interesting to see that vascular dementia has not changed, but Alzheimer's disease has, despite the fact there's no relationship to hypertension. My question is, how were those diagnoses made?
And to whom is your question?
Whoever spoke about it.
Yeah.
With regard to the disease, basically speaking, medical records and brain imaging we have mainly utilized. And then the results, probably we have confirmed with the autopsy. And those of them who accepted the autopsy, the same results were obtained. So pathological, definitive Alzheimer's disease and the non-Alzheimer's disease, we were able to differentiate the diagnosis.
Do you have standard criteria for diagnosing Alzheimer's disease and vascular dementia at pathology?
With regard to vascular dementia, the pathological standards are very difficult to establish. So basically speaking, Alzheimer's, the pure Alzheimer's disease, the pure lesions must be there for differential diagnosis. However, vascular mixed type may be creeping in to our diagnosis.
One more question. Oh, a question from Dr. Saxena. Or a comment?
Thank you. It's more a comment. I want to thank the Japanese organizers to have done such a good job, but I also have a request. The information presented in these 2 days was very, very large, and it might be very useful for us to share the PowerPoint slides unless the presenters have an objection. So my request is that possible?
I would hope so, but I cannot decide. I think the organizers are in the room and may consider that. I think it was done, at least for the UK event, that the slides were available a few weeks later on the website of Global Action on Against Dementia. So maybe someone here, Yoshiki or Dr. Endo, yeah, you can talk to John Rouse and then it can be made available for everybody.
He's not using the microphone, so translator cannot hear.
Or PowerPoint on the website.
Okay, fantastic. So yeah, the answer is yes. Thank you very much. Last question over there. Yeah. Maybe we should give one of the young people the last word. Laura, do you want to say something?
Please wait for the microphone.
Wonderful. So you're talking about having new voices come to the table. What are you going to do, or is anyone else from the audience could answer. What are we going to do to educate people about dementia, as well as to fund education at lower levels? Perhaps undergrad, bursaries, scholarships, to help get new innovative ideas to the table?
Well, one answer can be that we are looking in ADI at setting up a group of young ambassadors, and they could be the front runners to educate others. But of course, that's a very small undertaking. I think the suggestion from Jeremy and that's something Alzheimer's associations can do, go out to schools with programs to educate school kids. I think there's a response from the room. Professor Dawn Brooker, you have an idea or already have a program? She has a program.
No. Thank you. Dawn Brooker from UK. I made reference in my speech to an organisation called Interdem, which is a group of EU researchers, particularly in psychosocial aspects of dementia care. And we've just started a Dementia Academy, which is looking at early career researchers and PhD students who are interested in developing skills so that we can have exchanges between our different centres and to really start having a very key group of early career researchers. So we welcome you to the UK.
Thank you very much. And this comes back to the two topics of the session yesterday that we shared. Education and exchange of ideas is very important. A lot of things, a lot of problems that we identify, someone in the world has found a solution. It's just a matter of connecting the dots and make that available for others. I think that would be a nice conclusion at the end of the day. Again, thanks so much to the Japanese organizers, all the technical people, the translators who helped us very, very much during these 2 days. And one applause for you.